Okay, happy Saturday, everyone. I know, wow, I'm right on time. I said I'd be recording by 2. It's 1:58. So today we are going to do, just as a reminder, I know this is only technically it's the third week of school, but it's our second meeting doing it this way. I'm going to be doing an actual recorded lecture. This week is lecture, not so much guidance. Well, it's half and half, I would say. It's just the way I prefer to do it for this particular set of what do you call organs, if you will, or module, or however they call it in MedSurg. And I did want to start off with a couple things, a couple housekeeping things, just so that I didn't forget, which is, you guys do have a quiz today. I have the quiz open for 24 hours, and it's a little different than last time. And I know a few people got confused by that. I was trying to be nice and give you extra time, and then I confused you because quizzes are usually never due in the morning. So we got that cleared up. Everything's fine. So today it's open from 5 p.m. It'll be open until tomorrow at 5 p.m. So you have that 24-hour window to complete 5 questions. There's multiple choice. There's, I think, a fill in the blank, and I tried to switch it up a little bit. And then your next one that you have, your next quiz next week, I'm going to include an extra credit question. So I'm trying to kind of, excuse me, sorry, my dog. One moment, please. Okay, so that way that we can kind of spread it out throughout the semester, because it is only that 5 points throughout the whole semester. That's why it seems weird, 0.5, 0.25. I know it seems odd, but it's the only way we can do it to make it happen. The next thing I wanted to talk about was I was given permission. I think I did an announcement, but I know you guys are over flooded, I'm sure, with announcements. So I did put an announcement in that I am allowed to record. It was just getting kind of a little nerve-wracking of like what to do, what we can do, what we can't do. It's called FERPA, which is kind of HIPAA for students, which you absolutely deserve privacy. But because it's your class and you're in the class, I'm allowed to record it. I knew that. I just was hypersensitive and nervous about it. So I will post that as well. So on Monday, when we have our class, whether you're there or you're not there, it could be potentially beneficial. Somebody might ask a question or whatnot. So I will post that as well on Monday. So you'll have this, you'll have that. I do recommend watching them at least once. That's just my recommendation. The other thing I want to mention is about the announcements. For whatever reason, when I put in my assignments, I did not know that my quizzes don't show up. I have no idea why. I kind of still don't know why. All I did is a little tiny little thing in Canvas, and then all of a sudden it showed up. So sorry about that. Had no clue. Everything else shows up on the dashboard except that. So now I know that for some reason that and tests don't show up. So now I know how to do it. It's there. It's a nice reminder, I know, because there are so many things due. There's like 22. It was, a little overwhelming when I looked at it yesterday. So that's fixed and up. So hopefully that will help. The calendar that we talked about last time in class, so some of you may not be familiar with this, is working. And I know how to use that as well. So it should be working like every other teacher. It's just one special click. You have to do something. It's so weird. Canvas is so bizarre behind the scenes. Okay, so all of that, housekeeping. Monday at 8 a.m. we'll be having class because it's not a holiday. We talked about that. I have our quiz. Okay, so today is, we're going to be talking about skin disorders. A large chunk of if you've looked at the chapter yet, a large chunk of the discussion has to do with ulcers of the skin and staging and packing and wound, this and that, and a lot to do with changing dressings. And there's some even more advanced things that we're doing now. I do have 1, 2, 3 videos that I'm actually going to put into this video, and we'll watch them together. Those of you who I had when we weren't at the VA, you've seen one of them. It's super short. It's like a minute. It's about a wound vac. And then one of them is a different one I found. It's really, really cool. It's a little bit, if you're eating, don't maybe, or unless you're good on eating and watching what you're going to see. It's pretty a pretty large open wound, fresh, wet, and ready to have a wound vac put on it. So I thought that would be really cool to actually get to see it, especially if you haven't seen it before, and get to know why we use them and how they help heal wounds faster and whatnot. So that's kind of how today's going to go. Of course, we'll talk about other skin disorders such as psoriasis and the big things, the ones that we see a lot, right? You guys did a great job on your quiz. Your quiz one obviously was a little bit, not the quiz two is hard, but quiz one I tried to make a little bit easier just because it was week one. You guys were so overwhelmed, and why not? Okay, so let's go ahead and dive in with, I also have PowerPoints now too. So PowerPoint 1, I stole, or well, actually she gave it to me. It's from Lynn. So, but it goes with the previous one. So that's why under week 1 and 2, it's the same PowerPoint. So we're going to use that as well to kind of guide through the lecture. And then at the very end, I'll go through the book, and that's where I'm going to do kind of my guidance of things that might be important because you do have a test coming up. So I want you to be, and again, I'm making a study guide. It will be posted 5 days before your test. I believe your test is on the 20th, if I'm not mistaken. Please don't quote me. Please look at the what I wrote, but I think it's on the 20th. Okay, so just one moment. Let me pull this up. Okay. So I may have just recorded me trying to do that. I'm not sure. I'm not going to go back and redo that 2 minutes. So sorry if you watched that. If not, yay. Okay, so I'm going to go ahead and share my screen with you. And so as you saw, if you opened, or if and when you open up the PowerPoint, so the first PowerPoint is, like I said, it's split into 2. So the beginning part would have been chapter 53, and then this from here on would have been, I think that's why she probably didn't even put the chapter, because it's kind of mixed in together. So we're going to start by just discussing a little bit about pressure ulcers in general. This is something I think that we talk about a lot because it's obviously extremely important, especially with the population that we work with in our LVN or VN program. We work a lot in skilled nursing facilities where a lot of patients, unfortunately, can get pressure ulcers, as we know, everywhere, yourself included. I mean, depending on what's going on, we'll get into kind of the more specifics as good reminders and review. But a lot of the time in the skilled nursing facilities, and I'm not blaming anyone or any of the employees. I mean, this stuff does happen, and it takes a lot of work to prevent pressure ulcers, right? If you really think about it, it's not just, turning our patients and making sure that we're not, as it says on the PowerPoint here, under etiology, the friction and the shear and pressure. Yes, of course, it plays a large role, but what about nutrition? And a lot of the times, and this is not an ageist accusation, but working in a skilled nursing facility as an instructor, unfortunately, a lot of the patients get a little bit sometimes neglected, where that's why I love when we're there, because we can sit, I mean, eating is a very big part of culture too, right? And just human connection. And there are studies done that show that people will tend to eat more if someone is sitting there with them. In a perfect world, of course, that's how it would be done. Unfortunately, it's not usually done that way, and it's too bad. But we do the best we can when we're there, because nutrition is extremely important for just body function. I mean, this is my opinion. I mean, medicine is food. What you put into your body, not all the time. I mean, I know people can still get, ill or get cancer and things can happen to them, but I truly believe you are what you eat, if you will. So, sorry, I was looking at, I'm just imagining Lynn trying to explain this specific lecture, because this one is hers. So remembering that it's not just the things that might pop into your mind at first. What can I do to actually prevent, right? Because we always want to prevent things from happening. We're always thinking, what is the next thing? Okay, I'm noticing this patient's losing weight. Immediately, I'm going to think, okay, maybe they're not eating, or maybe there's a secondary thing happening, or okay, this could potentially be, you're going to have more bony prominences. We all have bony prominences on our body, but meaning your elbows and the bottom of your what's the thing called that you walk on? Your foot, your ankles, right? So bony prominences are much more likely to get, just like your sacral area, where you have that bone that's closer to the surface of the skin, is going to be much more likely to potentially have skin breakdown. Therefore, you're more likely to get a pressure ulcer there, which is why we move you the way we move you. So again, you all know that you're doing it, but knowing and backing up behind, why am I doing this? So if you're in a room with a patient and let's say their friend's there, or their child is there, or their grandchild is there, and they're asking you, oh, why, what is this? Or why don't you use this? Or what are you doing? Or why are you moving them every 15 minutes or 2 hours, or whatever it may be, or putting this cream on, or doing a certain thing, or doing a dressing change, or a wound vac, you'll be able to actually explain, this is why we're doing this. And they may even have the question of, well, why is it there? That's such an odd place. Why would they get it on their butt? This is, I'm talking as a family member, and you'd be able to explain, well, this is an area where skin tends to break down very easily. This is the sacrum. It has a very thin layer of skin. And then what happens? It's not just the sacrum, because a lot of the times it does move down to the buttocks, right? Because it's right there. It's right next to it. And then things can tunnel, and it can become a very large infection. And as we all know, what happens then? We have an elderly patient who's then trying to fight off this infection, who's not eating very much, who's probably not getting enough protein. There's just this dehydrated, lack of oxygen to that area. There's just one thing on top of the next, on top of the next. You're just chasing it basically at that point, right? So once we see that reddened area, it's like, oh God, and we do our best. So please remember, in your career, I don't care where you go, if you're a CNA for the rest of your life, if you're an LVN, an RN, no matter where we are in healthcare, we should always, be on the lookout for this and take responsibility. So just my 2 cents on that, at least. Okay. So I wanted to talk a little bit about that. I'm not going to, the stages, just as a side note, there is a question on your quiz about the stages of ulcers. It's interesting to me. Stage 1 tends to be very easy, right? Just looking at this picture here, to me, that looks like a rash, actually. But if I'm seeing red and I know it's a bony prominence, I'm going to be looking at that. Oh, something that I really want to mention, that sometimes things almost look contradictory. So if you read the chapter, hopefully you read the chapter, I think it's on the first page, maybe it's the second or third, but it talks about, the bony prominences, and those that tend to be of older age are more susceptible to this. Just like anything, certain people are more susceptible to certain things. People that smoke cigarettes are more susceptible to lung cancer, but people that don't smoke or are not around secondhand smoke can get lung cancer. So not everything's always obviously 100%. We know about the spectrum. We know all about that kind of stuff. But also those that are obese are very, or not even obese, I'll just say overweight. And you think, well, when I first read it, I even looked away from the book. So I was like, you're going to figure this out. This is a critical, that's a really good critical thinking question. It's not on anything. It might be later. So listen to this part, please. Listen to it all, but focus more on this part. So you have somebody that we get that part. We get the skilled nursing facility. We get the skinny, you don't have much that's just sitting there, and that skin is losing oxygen, right? And we need oxygen in order for your tissues to be able to breathe, whatever. Yeah, they're breathing, right? They're getting oxygenated, and it's a beautiful thing. But then I was like, it took me a second, just because, I don't do this every day. And I went, okay, so somebody that is overweight, I think that's the word they used, could potentially, if they're, laying down for a very, very, very long time. And it made a really good point. And I want to read it specifically, but basically it comes down to vascularization, but I actually wanted to read it. So the way that, because I just like the way the book words it. So the way the book actually words it is older adult patients have increased risk because of normal aging changes of the skin, and thinning of the skin. I didn't mention that, but thinning of the skin, of course. And thin patients are at greatest risk because they have little padding when pressure is present. They do say obesity. Obesity is also a contributing factor because adipose tissue is poorly vascularized. So, and that was such a, and I did, after about, I'll say 7 minutes, remember, because I really wanted to remember it on my own, like, okay, think about it, like really, really think about it critically, get to the answer. And that's a beautiful thing about nursing. You get all of this stuff and then you can finally like get to it yourself a lot of the time if you really think about it. If adipose tissue, which is fat, that's fat tissue, right, is poorly vascularized, and you have a patient that is obese, they too, which, I mean, these are totally opposite ends of the spectrum, but they're both at that risk. So this is why it's so important to understand things. And like I said, we're not going to remember every single thing we read, every single thing we hear. It's what, I mean, yes, I wish we could, and everything's important, but certain things are maybe a little bit more important. Like to me, that's very important. It's really important to know who's at risk, who's at risk for getting this. How am I going to prevent it? And how am I going to make sure that my patients are safe, basically, right? Okay. We already talked about this, the common locations for pressure ulcers having to do with the bony prominences. I mean, you can clearly tell by this gentleman who is, I think, yeah, looks like a gentleman who's laying down. It says if the patient rests on his or her side, there's a lot of, I mean, look at all those blue dots. That's a lot of areas that are putting pressure down. And this is why we move our patients so often, right? And why we use certain devices and do certain things to try to do our very best to prevent this from happening. Something that I've seen a lot, and I'm sure that most of you can agree, is those that are in wheelchairs. I don't know if it's just that, and I'm going to say we, because I mean, I can see myself potentially doing this too. I'm not perfect, and I don't work in a skilled nursing facility, and I don't work with, I mean, any patients I usually work with in wheelchairs in my job, they move themselves, right? So, but unfortunately, if you're less mobile or able to move yourself, you depend on others to do it for you. And if you're in a skilled nursing facility where, 75% of your population is either in bed or in a wheelchair, they're not really getting up, they're not moving, they're not getting that circulation going. And I think from my experience, a lot of people in wheelchairs get forgotten. We need to move them, even in the chair, just move them around, put a pillow, do something, like get them moved away from that position to help, again, prevent. We're preventing. We don't want to see bone. We don't want that. At least I don't. Okay, moving along here. So a lot of this has to do with the ulcers, and then we'll move on to the videos, and then we'll move on to more of the lecture without the PowerPoint, with me talking a little bit about psoriasis and other just general skin disorders and whatnot. Okay, so we know about the shearing with the patient sliding down the bed, being very, very careful, and remembering why we're doing what we're doing, and teaching. If we see any doing a CNA, a VN, anyone, a doctor, I don't care who it is, we should politely correct people or help teach people. Maybe your fellow student, oh, you know what, actually, let's do it this way because we want to prevent this or whatnot. So it's a really important thing, because imagine, if you really think about it, in a 24-hour period, how many times a patient is actually moved, especially if we're trying to prevent, we're always trying to prevent pressure ulcers and whatnot, and many things. Imagine how many times I keep bringing up skilled nursing facilities because that's where we usually tend to be, but imagine how many times they're actually moved in a day and what that can do to the skin. It's like, if even yourself, I mean, we have this pretty little skin here, all moisturized. And if I'm continuously rubbing on my skin, and I do this every single day, let's say once an hour for 10 minutes, it's probably going to break down, right? So thinking of it that way, even though I have healthy skin and I eat healthy and drink water and all that stuff, it doesn't matter. that can still happen. Okay. Oh, sorry. So the staging, we talked about this, or we're going to watch the video about this, but just, let's quickly go over this just as a nice recap, if you will. So stage 1 through 5. 5 is, I don't know if you've seen it. It's just so sad. I will say one thing, it's almost like burns at some point. Not that it doesn't hurt, but you'll actually see in the video that I show you that's a little bit I'm gonna say gruesome. Actually, it's pretty I can stomach a lot, and I was kind of like I was eating, of course. But I was starving, so I had to eat. So stage 1 is going to be that non-blanchable erythema of intact skin. You'll see some discoloration. Usually you're going to feel heat on that area and induration of hardness of the skin. So that's usually, in my personal opinion, that's one of the easiest ones to be able to tell. And understanding the verbiage, going back to also the key terms. Please take a look at the key terms. I think the key terms are always very important, because knowing the key terms in the beginning of the chapter helps you be able to understand what they're talking about in the chapter, right? So I don't even know if this word's in there. I think erythema is, but erythema has to do with redness. Non-blanchable has to do with, so something, if you think of the word, I was trying to come up with what's it called? The thing that you do. Sorry about that. Try to get creative, and I unshared you. Okay, so I was trying to think of a good example of like blanching. I was thinking of like cooking, and it just didn't happen with me. But if you can think of something on your own, if you have trouble remembering what that means, then that would be great. So what non-blanchable erythema has to do is, so it's kind of like a good example would be cap refill. Apparently I have none because I don't have any. Can't see my nails. But if we were to have somebody and I could do a cap refill on them, why do we do a capillary refill? We do that to see how long it takes. Basically, it's a very similar thing. How long does it take for the vascularity to go to that part of your body, right? So it's the same thing with when we're staging pressure ulcers and or ulcers in general. So if we have a non-blanchable erythema and the skin is intact, so basically I'm going to that area and I'm going to want to press on that redness, because erythema means red. So here, let's just pretend it's here, and so I go ahead and I'm pressing down on it, not too hard because it might hurt them. Probably will. So we do this, and I'm going to look, and as you can see, it's kind of hard because I'm light skinned. Did I say skinned? Skinned? I don't even know. Whatever. And do you see how it kind of turns? You probably can't, but it goes lighter. So I'm pressing on them. It's red. It goes lighter to a whiter color, and then it becomes red again. So that would be non-blanchable. And non-blanchable is not something that we really want, because what that means is that big word, non-blanchable erythema, even though it's still intact, that's great. I'm happy about that. Unfortunately, this could potentially very easily turn into a stage 2. Why? Because non-blanchable means that skin is getting not as much blood, which blood equals oxygen, as it should, because it's not staying that color. It's not going back to the color it should, right? It's still red. So that's going to worry me, and then I'm going to think of all the ways that I can try to prevent from what's going to happen next, which is stage 2, which is partial thickness skin loss involving the epidermis, dermis, or potentially both. The ulcer is superficial and presents clinically as more of an abrasion or blister. I think this one also, for me personally, it's once you get down to stage 3 and 4, I don't know why those tend to be more difficult for me. We all have our thing, but the first 2 seem very easy. The first one, it's still intact. Okay, got it. The second one, same thing. The skin is intact, but it's more like if you were on a carpet and someone like drug you across potentially, and on your back you have like that abrasion area. It's almost like scratches, and then potentially blister depending on the person and whatnot. Stage 3, full thickness skin loss involving damage to potentially having necrosis, which is death of tissue, and may extend down but not through the underlying fascia. So different types of tissue that are deeper than just your epidermis and dermis and whatnot. So you're going down pretty deep now, almost you're headed down to the bone. And then stage 4, extensive destruction of the tissue. We've got tissue death with necrosis, damage to the, once we get down to that muscle and bone and all those supporting structures, that's a really scary time. And then we have that tunneling, and as I'm not sure if anyone has seen it, I know you practice in the lab with it. Totally not the same thing. It's so hard to recreate, really, unless you get really creative with it. But tunneling and packing and all that stuff. And then number 5 is just unstageable. It's just open, basically. And at this point, I would hope a physician or NP or someone would be on the team and on board and doing certain things like ordering wound vac, which I will show you, special potential antibiotics. And what antibiotics would you do? I would do a swab and see which one we have, what else is going on with this patient, and what else can we do to potentially help, either help heal. And it's hard. It can take a year, months to year. I don't know about years, but a very long time sometimes for these ulcers to heal. And it's usually what we want from the inside out, right? Okay, so these are just some pictures. They're not too big, but to kind of show, and I'm sure you've seen several of these, at least stage 1 and 2. Okay, so this one here is interesting to me because if you take a look, so basically what happens is, I guess the best way to explain it is your dead skin cells that are obviously, as we talked about earlier with necrosis, they're not detaching. And we're not getting obviously blood flow, necrosis. We can see the dark color, and your dead skin cells are basically not falling off; they're sticking to it. And this is kind of what that would look like. And that's another reason why it is so important when we're doing assessments on our patients. I don't care if we're doing a quick in and out just to make sure our patient's okay. Look at their ankles. Look at their elbows. Look at their sacrum. Just a quick boom. Because we can tend to miss things, unfortunately, if we don't do that. And we don't want to miss things like this, especially if it's preventable, which most things are. So there are, of course, extrinsic factors as well as intrinsic factors. We talked about a couple of them. My apologies. Intrinsic meaning things versus extra meaning outside. Intrinsic meaning inside. So immobility, we talked about with potentially being wheelchair, a lot of being in the bed, maybe on a walker a little bit, but just there's not a lot of walking. Imagine how much walking you do a day and how much circulation is going on, right? Sensory loss, potentially. The older we get, we might not have as much nerve feeling. If you've, again, just pull from where you've already been in clinical. Age is definitely a big contributor. I'm trying to think of the youngest person I've seen. I have seen pressure ulcer on, I don't know if 30 is young to you, but 30 people in their 30s. And those usually are people who are either very, very malnutritioned. So they have a lot of bony prominences. They're bedbound, potentially HIV, very sick, as far as autoimmune, that type of thing. Of course, if we have a low immunity, we're going to have trouble fighting things off, and things can get worse. So those would be a specific population that could be more at risk, which is what it says right here. Other potential comorbidities, right? Other disease processes that might be contributing. So again, looking at the bigger picture. I have a patient come in, 45-year-old male. He's coming into the skilled nursing facility because he just had surgery and he needs some rehabilitation done to help him be able to walk again. I know that he is malnutrition because he's 95 pounds and he is 5'9". That's really small, but whatever. You get what I'm saying. and he has low appetite. So I'm already thinking, I'm like, okay, potentially medication that can help with appetite. Sorry, you guys. And I can't pause it on the screen. So my apologies. I can mute it and yell at them. Hold on one moment. Okay. So, okay, then we go down body type. We talked about that as far as being very, very thin or obese. Poor nutrition. We talked about nutrition, the importance of it, protein, healing your body, infection, just in general. We're not quite sure why she put that, but maybe you've had a previous infection that could turn into a pressure ulcer, right? That would make complete sense. And incontinence, that is so important. I'm so glad she put that on here, because if you're incontinent and you have that liquid now or urine that's sitting on your skin, what's going to happen? Potential even more skin breakdown. So there, I mean, we're just, it's like fighting against an unfortunate, almost, I don't want to say inevitable, but we all know it's so common and it happens all the time. So really staying on top of things, and the more we stay on top of things, and I will tell you one quick story. When I did my preceptorship, I don't know if you guys do that anymore, but when I was a VN, we did a preceptorship where we would go kind of basically by ourselves I went to Our Lady of Fatima. Had a great experience. I was like a nurse, I felt like a real nurse when I was there. And and this stuck with me this many years. I had a nurse, and she told me, she said, the importance of certain special things. Like one was having patients that are incontinent, as well as patients with poor nutrition. And she said, I don't care if I get in trouble or not. I'm so sorry, you guys. My apologies. One moment. Madison is very upset. I might just let them out. So, and she said to me, and I don't care if I get in trouble, or I don't care, I will take that extra 10 minutes to make sure that my patient at least eats 50% of what's on their plate. And that was a big part of our role. And just that, again, that passion and that understanding of why she was doing what she was doing. It wasn't just to, oh, here's your food. Okay, walk away, do what you need to do. I have 32 other patients. And same thing with those that are incontinent and not